Well, good evening, everybody. I hope that you are all healthy and well, and I hope that you've had a great weekend. This is Harold Pian, and thank you for joining me today on this video. It is April 27th, Monday in the evening, and I just had dinner, so yeah, it's a busy day today, especially with the fact that we got notice that our TAS plan was approved. I got the email early this morning. So first and foremost, thank you to our Department of Aging rep and of course the managers and the team up at CDA for taking the time to not only review our plan, but I'm sure the hundreds of plans that are being submitted by the providers out there in our state. So I thought I'd do a little video about the TAS plan and at least the email that we received regarding the approval, and probably an important discussion that might be of interest to you, forms. Now again, can't go into too much detail because forms, as I'll talk about a little bit later, can vary widely from center to center. Although I'm sure a lot of the core base principles should be consistent amongst all centers. The shape, the form, how they look, the feel may be different. So I'm going to be talking about that a little bit today. Now, before I go into it, just a disclaimer. I am doing these videos as a little way to contribute back to the CBAS community, to all the centers that are providing important services to the participants that we serve, particularly during the COVID-19 crisis. Again, you know, the purpose of these videos may not necessarily be to provide detailed step-by-step guidance, but a general framework that can help guide your discussion amongst your team and the actual development process of forms and policies. I do work with some centers, and I do remind them that the forms and policies and procedures I do provide for them are proprietary and confidential, and I am thankful with the fact that they are respectful of that. But nonetheless, obviously, this video and the other videos that I post, whatever value you can gain from that, it's there for you to use. So all I ask is that you provide good services to the centers, to the participants, and that we do our best as a provider community to provide services that are effective, but yet following regulations and with integrity. You know, all it does is take a couple bad centers out there to really make this, could really hurt a lot of other centers that are really doing a good job out there. So I'm confident of the fact that each of your centers will do their best to provide good services and with integrity and honor. So let's move on. So on the left here, you'll see the email I received. I blacked out the name of the center and the name of our aging rep. But you can see here, this is what your email will probably look like. Mine says, "Good morning, Harold," and name of the program director. The Temporary Alternative Services application was approved on April 24th, 2020. So this was Friday, and I got the email Monday today, April 27th. So thanks for sending out so early. You see there's 7:15 a.m. Now, what I'm going to be talking about here is the bottom note. CDA approval of your TAS plan of operation does not extend to any provider-developed forms that you may have included in TAS application packet. Now, excuse me, it is the responsibility of each provider to ensure that their individual forms align with CBAS program requirements. I mean, you know, as I mentioned right off the bat, a form at one center may not look like the form at another center. Of course, the centers I work with, the forms will look relatively the same, but I do adjust the forms and policies and protocols according to each center's operations. But nonetheless, this is important to note. So this video will talk about forms and provide some basic ideas. Okay, So again, here's another disclaimer. These forms and processes have been developed for unique providers. These are by no means the only correct or approved forms, but were developed by integrating prior development experiences similar programs. And some of you may know I did develop from scratch a care management program, care coordination program for Anthem Blue Cross for a certain subsection of their provider, their member community. And that was like 2011 to about early 2014. So this is where I was able to gain a lot of my experience. Additionally, I did get training in care management, intensive care management, and went through a certification course as well back when I developed that program for Anthem Blue Cross. But nonetheless, let me get back into this. So there are two types of forms. They mentioned provider developed forms. And these forms are in addition to what our standard set of forms may be. All of you should be familiar with these. Your assessment forms, quarterly reassessments, your initial assessments, right? And I can go on a whole video just on that. And to be honest, it's hard to do that because there's still a lack of clarity and certainty with what is expected. I do believe that quarterly assessments are now required, and reassessments I assume will be. But at least in the centers I'm working with, I'm assuming that they will do quarterly and reassessments. Okay, so flow sheets and progress notes, these are all things you should be familiar with. And at bare bones minimum, you should be documenting all your TAS services, assessments that you are doing in your existing forms system. Flow sheets, progress notes, assessment forms. Now, there are provider developed forms, what I initially called CBAS CM, which is equivalent to the TAS program. So CBAS CM, TAS service documentation. If you don't know, CM stands for care management or case management. And included in these might be, again, I'm saying might be because at least in the centers I work with, I have developed a subset of assessment forms for this program, in addition to some consent forms, also action plans, and then CM action forms, which document more of the day-to-day services that are being provided by the centers and the staff. Now, on a separate note, for assessments, as I mentioned, we are doing quarterlies and we are doing reassessments, and we are integrating as much of the MDT as possible. So that's something to keep in mind. In terms of action plans, I want to clarify, this is separate from your IPC. So at the centers I'm working with, we are continuing to develop IPCs. Yet last week or about a week and a half ago, I did provide instruction to the program directors on how they should be writing IPCs. So literally in the IPC, my direction to them was to keep the base IPC with some side notation stating that these are meant to be provided during normal or usual CBAS program operations. And then we created a whole subset of interventions that are meant for COVID-19. And so we clearly delineate that in the IPC. I believe that CADS and aging might have provided some guidance about where you should be documenting these and like certain portions of the IPC. But for the centers that I work with, I've even prior to the call today, I had instructed them to provide a modified IPC, it's a hybrid, keeping the old interventions and adding new ones, just in case, because we don't know when we'll get out of this situation. Let's theoretically assume that we get out of this COVID-19 situation in 2 months. And let's say you modified all your IPCs to reflect only COVID-19 interventions. Well, the issue is, if you did, then and we go back to normal, quote unquote, normal operations, if that were to happen, you would have to redo all your IPCs. So what I decided about a week and a half ago was that IPCs, we should keep the base IPC and clearly denote that it was meant for CBAS, for COVID non-COVID, normal CBAS operation, and then amending the IPC to have COVID-19 specific interventions. That way, in either scenario, we have an IPC that reflects that. Now, the action plan is very important, and I'm very happy to hear that, at least for this particular element of the TAS plan, TAS program, action plans, it is recommended that you visit them weekly. Now, this doesn't mean they have to be modified weekly. What I am telling our staff is that they should be visited and reconsidered and reviewed weekly, and document that the action plan has been reviewed, and simply certify that. Print your name, sign, and date. So that should be happening weekly. And if an action plan does change, then of course you should modify the action plan and then have an associated progress note of some sort that shows what was changed and why the action plan was changed. Okay, so again, when they mention provider developed forms, these are forms that are referring to that centers might come up with in their creative efforts to better document TAS services. And again, this is TAS services, temporary alternative services. So this is something in prior videos you'll see from weeks and weeks ago, that I reminded the viewers that this program is meant to be temporary. So it was kind of nice that the term that was called was TAS, temporary alternative services. So that was kind of cool. Okay, so moving on, that's what the email looked like, at least for, this is one of the letters that I received, or emails I received for the approved TAS plans that I got today. So moving on, I had this model in another video, and this is important because I want to remind you that, well, this is a little diagram that I came up with to help you contextually, or at least theoretically, think about the situation. On the left, the dark blue circle represents ADHC CBAS program services. That's what business as usual looked like, and the whole universe of services and programs and regulations that came with operating CBAS under quote-unquote normal circumstances. On the right side, you see the sky blue, the light blue bubble circle, and that represents what care management programs might look like in the general community, in the general healthcare community, right? And what we had to do, and again, I came with this about a month ago, we had to come up with an alternative grouping of services that combine both the ADHC, some ADHC elements and some case management elements, and we came up with an alternative services model. And you see at the top the red brackets, but within the context of COVID-19. As I mentioned in my other videos, if I were to create a TAS program or CBAS CM program, it would look different if we did not have the COVID-19 mandate. So it's important to understand the parameters in which you're trying to create this program. So I wanted to show this, okay, because it's meant to be temporary, and it is meant to integrate the best of care management and the best of ADHC CBAS. But in reality, what I always tell the staff is this is a new program. It is happening on ADHD centers, but this is in a interesting way if we think about it, this is not ADHC CBAS program. This is a new program that we're creating. So when I work with the staff, there's a lot of frustration. There's a huge learning curve because this is a new program. And if you're not having struggles, and if your staff aren't having questions, then to be honest, I think there's something wrong. Because if they're operating as business as usual, and your approach and your management style is business as usual, I'm going to tell you, I would have like these red flashing lights flashing just to warn you that you're probably leaving something out. Because this experience should be challenging. It should be, to be honest, it's going to be frustrating at times, but yet it should be rewarding because you are really working in a new environment, creating a new program. Okay, so I'm going to talk about forms, and it's loosely, I use this word form to loosely include all forms of service documentation, and we talked about what those were, right? Assessment forms, flow sheets, and progress notes. But it is important to remember that your forms are only as effective if they are properly implemented. So you could have the most beautiful forms, the most detailed, well-designed fancy form, but if the forms are not implemented properly, they're just pieces of paper. And they're not going to help you in terms of what you need to be doing for documentation. So a couple pointers here. Keep in mind, this is an organic process. You should be going through several reiterations and expect a massive learning curve. And I emphasize that word massive. And you should be having trainings again and again and again with your staff, because the natural tendency is to fall back, well, this is how we used to do it when we operated ADHC and normal. Well, we need to retrain our staff and the management and the ownership to understand this is a new model and this is an organic process. And as long as you're growing and improving and progressing forward, that's good, right? 2, provide for comprehensive capture of data. So you should design forms that allow comprehensive capturing of data, services that you've given, great documentation, really documenting all the great work that you're doing, but yet keep it time efficient for your staff. Now, there might be an assumption that, well, there aren't any participants coming to the centers, so the staff should have a lot of time. Well, yes, in a certain sense, that's true. However, it is important to remember there's a massive learning curve. This is a new program. So the time that is not being spent working with participants should be spent providing services, TAS services, but also relearning a new program. 3, ongoing trainings. I have trainings every week with the staff. And I might be saying the same thing 3 or 4 weeks in a row, and it's okay. It is completely okay, and I remind the staff of that because this is a new program. Okay, and expect many questions. Regular review and audit of forms. Review what your staff is doing, what your team is doing. Okay, sit down and have meetings and brainstorm. How can the forms be improved? How can the processes be improved? Right? Have a Q&A session going on here. Right? 5, use existing documentation requirements. So if you create any new forms for the TAS program, make sure you're integrating the basic elements that was required in old documentation or standard documentation, signatures, dates, making sure it's accurate and credible completion, right? What I am requesting at our center is that we still use, as you see in point 6, we still integrate the standard forms. Okay, so, you might do it differently. I'm not telling you should do it this way, but at least with the centers that I'm working with, they're integrating the new forms that I created with the existing form system structures so that we have a larger, picture or breadth of documentation that's being collected here. Okay. Now, with proper implementation only comes from the development of effective protocols and policies. So again, if you see here, forms are only effective if they are implemented properly. Now, in order for proper implementation to take place, you should have protocols and policies in place as well. So a couple points about this. Develop a TAS guidebook for your staff. These are some of the things that I included in the guidebook that I made. Talk about what the objectives of your TAS plan is, what your TAS program is. The protocols, cover the protocols. How are you going to deliver meals? How are you going to do face-to-face services? How are you going to do telephone calls, right? Safety, talk about safety for not only for your participants, but also for your staff. How are you going to maintain safe environment for your staff and participants out in the field? How are you going to maintain safety within the center for your staff, right? So safety is exceptionally important for this COVID-19 situation. Then also provide a description of services. I would literally delineate and describe, well, what is a telephonic service by a social worker for social support? I would describe what each of your core service elements are. So this way that if you have a guidebook, your staff can refer to this at least for general refreshers, right? And then 2, regularly update your guidebook. Thankfully, from the base forms that I created and the policies that I created about a month ago, I have modified them and improved them, but it's about 95% of what was created before has remained intact. but the 5% are like little, tiny little things to make the process more efficient or make the form more comprehensive. So thankfully, most of the forms I created were pretty much 95, 97% intact from its original base from about a month ago. So having a guidebook can help, that describes protocols and policies, can help ensure that whatever you're doing is being properly implemented. And just a note here, the minimum is just a minimum. And I'm going to talk about this in regards to this slide. Development of effective protocols and policies come from a clear understanding of basic principles related to care management and similar programs in the context of CBAS regulations. So with this in mind, so good forms mean good implementation. Good implementation means having good protocols and policies. But having good protocols and policies ensure that you are trying to, as closely as possible, abide by the regulations that are established. So let's go back to this slide. The minimum is just a minimum. And the state, Department of Aging, and other agencies might be issuing ACLs, all center letters providing further instruction. And here, this comes from the ACL from April 13th. April 13th, and I think the date is incorrect here. It should be April 13th, 2020. And so if you look here, the yellow requires the base minimum. But again, and I'm not going to go into that, but if you look at the left side, these are the base minimum things you must have in place. Weekly COVID-19 risk assessments for any participants that are actively still enrolled with your center. Also, making sure that you have a minimum of 6 hours of participant center access telephonically. 3, staffing. Past ACLs have clearly explained that the minimum staff you need are program director, nurse, social worker. And then 4 refers to the letter that's on the right. This was an excerpt that I took from the letter, and those are the billable minimum services. But I want to encourage you to really think about that, the fact that this is just minimum, okay? And I know it's tough. I know things are tough, and this is a huge, massive effort. But what I am recommending for the centers that I work with is we steer away from just doing the minimum, okay? There might be some days where you might just do the minimum. But to simply do the minimum every single day that you're billing is very dangerous. And in fact, that's not right. That is not a good thing to do. You know, it's, I was involved with audits and investigations for many providers that may remember that back in, 2008, 2010? I can't even remember, right? And so, you know, I have this like inbred fear about like, you know, making sure we properly document everything. So I would really, really encourage you, follow the bare minimum requirements that are outlined here, but keep in mind that is just the minimum, okay? So when I refer to service, I always refer to them as units, service units, okay? So these things are service units. So you may need one minimum service unit. However, you can have multiple service units in a day. Yeah, you're still going to only be able to bill one day, right? But if you are just doing the bare minimum each day, I don't think that's proper, because some days, you know, remember, this is person-centered. One day the social worker might call, then may need to refer to the nurse, and nurse may need to speak to them. And by the way, you send them a meal later in the day, and you get to visit them, you know, see them face to face as you're dropping off the meal, right? Of course, using proper protection. So in a day, you can have multiple service units being provided, although you're just billing one day. So just something to keep in mind. So back to this. So again, to have the forms are only as good as the implementation process. The implementation process is only good as the protocols and policies that you establish. And those protocols and policies should be in line with the ACLs and any existing regulation. So here, 1, develop your guidebook with Title 22 Welfare and Institutions Code in mind. 2, also integrate safety protocols from the CDC and reliable sources. And under normal circumstances, we wouldn't be so focused on CDC, right? It's because of the COVID-19. As I mentioned early on in my little diagram, we're developing alternative services within the constraints created by COVID-19. So definitely integrating safety protocols into your TAS plan and ongoing services. 3, well, I already mentioned this, but refer to ACLs that are being issued out by Department of Aging and other governmental agencies. Finally, don't take the flexibility for granted. And what I'm referring to is things like all you need is a program director, nurse, and social worker. However, at the centers I'm working with, we are integrating as much as possible OT, PT, LCSW, RD, speech if needed. We are doing our best to integrate them still in the MDT. Now, there's going to be a question, well, how do they really benefit? Because, for example, participants can't come to the center. Well, yeah, obviously it's going to be very limited. But still, there are certain things that the OTPT might be able to do in terms of contributing to a exercise program. One thing we've done, I created a separate YouTube channel and we uploaded an exercise video that our participants saw every single morning. Now, what value might that exercise video give from another exercise video that I just download from another website? Well, one of our goals is to help create structure, and the structure helps provide psychological stability. Well, if they see a video, an exercise video that they are familiar with, I wonder, what's the probability that they're more likely going to feel comfortable because, hey, this is something I know. Even hearing the music or seeing the pictures or the video might provide not only a physical benefit by helping them do the exercise, but even a psychological benefit because it's something they're familiar with. Okay, so again, don't take the flexibility for granted. I mean, this is just an overview video, and there's so many things that, assessments, how do we do that? How do we provide services? So I'm not going to go into this video, but I wanted to talk on a very general level about forms. So I want to talk about some case management functions. And this isn't taken from CBAS or Title 22. This is taken from a national organization related to care management, some prior training that I received. So if you look at these functions, actually they're very, very similar with what we're doing in ADHC as usual and in the TAS plan. It's very consistent with the services that are being required in the ACLs, right? We still want to be person-centered. Number 5, involve patient in decision-making, right? We're still there to advocate for them, right? We're there to educate patient and members and their healthcare delivery team. We're doing constant assessments. Action plan, I'm going to say it again. Action plan, I'm reminding our staff that you should be reviewing the action plans weekly. Again, doesn't mean you create a new plan every week, but you document that you've revisited that plan to see if there were any changes, okay? Standards of practice. We've triaged our population. That was one of the first things we did. That's one of the first things we did, right? Identifying our high-risk cases, right? Appropriate informed patient consent. Now we have the participant agreements on file and the other enrollment docs on file, but I have other consent form, and it's not technically a legal thing, but it's more of a buy-in process that I integrated in that form. We receive a verbal consent, and the reason for that is that when we first started this about 3 weeks ago, what was it, March 23rd, around there. First, we sent out a letter introducing the participants or notifying them of the pending changes. And then we let them know that we're going to be providing these alternative services. At that time, we called it alternative services as well. And we got consent from them. And it wasn't something they signed. It's just we let them know and they said, yeah, I'd like this, because we have to give them an opportunity to say, hey, no, I don't want this. Because there are participants that may say, I don't want to be involved. And we document that. Okay, so we know in the charts that we have reached out to them, but they have all the right to refuse services. But what I found is they may want, let's say they may want a call but not a meal. But what we found is that as time passes, a lot of these individuals that didn't want meals for whatever reason now want meals. So that's one prime example of how an action plan changes, because now they want meals, or now they want more calls than once a week. Okay, so number 5 talks about prioritize short, medium, long-term plans. In our case, the long-term plan is IPC. The short, medium term are our action plans. Okay, and then of course you're going to monitor progress on plans in your documentation. Okay, progress notes, flow sheets, and any TAS related, TAS unique forms that you might be creating. And then finally, facilitating coordination, communication, collaboration. Call this care coordination, liaison. This is so important. And these are all elements or services or actions that if you provide, be sure you document, because those are really important services. And in fact, I believe even if you were to do that one day, it still meets the minimum requirement for billable service. Even though you theoretically may not have spoken to the participant that day, but you called the doctor and you document it, and because you need to update them about their status, their situation, their health condition, or clarifying medications or prescriptions, whatever it may be, calling their psychiatrist. Even though you may not have spoken to the participant directly, but you did speak to one of their allied professionals, well, guess what? You should document that. Because according to the ACL, that is countable as that will help you meet the minimum billable requirement for that day. So the rest you can take a look at. Oh, number 14 is very important: preserving patients' privacy, confidentiality. So whatever alternative televersion, remote service technologies you might be using, make sure they're HIPAA compliant. Make sure they will protect your participants' confidentiality. Okay, so I tell my staff, don't call them with your personal phone. Don't be texting participants with your personal phone. In fact, I tell our staff to call using our center phones, right? Using center approved HIPAA compliant emails. Okay, so something to keep in mind, which is critically important. So, finally, there's so much to this, and certainly one video isn't going to cover all the required parts and elements that you would need to have in a great form, because this term great form is going to be very relative. There is no standardized guide out there that tells us what is a good form. And again, as you saw in this email, CDA approval of your TAS plan of operation does not extend to any provider developed forms. So as you develop your forms, be sure that you are integrating the basic required elements of what good documentation would entail, right? So with that, we'll call it a day. I know I rambled on, and I just had a lot on my mind, but I hope you got some value out of this video. If you haven't already, you can subscribe to the channel. So I will try to put up videos, and be sure you put the bell so you can get alerts as to when I do upload a new video. So with that, I'm sure many of you will be receiving approvals for your TAS plans. I'm not sure how many have been approved as of today, of April 27th, but it is a blessing, and I thank the Department of Aging team for having approved the plans that were submitted. And I wish each of you the best in your TAS program development efforts. With that, we'll call it an evening. Thank you so much. Bye-bye.